Welcome, my trailblazers. Welcome to today's DigiPath Digest. And I'm going to start with a few updates because this week was pretty special. You guys showed me so much love. And by so much love, I mean we have like over 1,600 new trailblazers joining the newsletter. Because I decided that even though I'm still working on the book updates, you should see the code to the book. So if you don't have this book yet in the digital form, because the code is for the digital form, click on the code and you can get the book.
Learn about the newest digital pathology trends in science and industry. Meet the most interesting people in the niche and gain insights relevant to your own projects. Here is where pathology meets computer science. You are listening to the Digital Pathology Podcast with your host, Dr. Alexandra Zhurov.
So a crazy thing happened. Okay, so 1,600 people joined the newsletter, the Digital Pathology newsletter. This is amazing because I decided that, hey, this book, even though I'm working on the updates, and because if it's not your first time here, if it's your first time, I'm still working on the updates. But like the stuff that's in the book is still super valuable for people starting their digital pathology journey. So I said, okay, let me just put it on social media again. And 1,600 people wanted the book. That means I didn't do a good job giving it to you in the first place. And that means that we have now like over 10,000 trailblazers on Facebook. And yeah, the newsletter grew substantially. The book, if you don't have the book yet, so that's one thing. And the big part for you, thank you so much because you make this technology move forward. Basically, I'm teaching it to people who will take it and actually implement it whenever they get the chance. And even if you don't yet have a scanner, if you're still working with a microscope, it all starts with awareness and knowledge. So this can be your first step. Digital Pathology 101 book. And then we decided, and by we, I mean those who joined the live stream last week, that we're gonna talk about the guidelines published by Polish Society of Pathologists. I'm going to put the QR code for the book later as well, if you want to check it out, if you don't have it yet. And then I have a little surprise or like a little special Valentine offer for you as well. You might have seen it on social media, but maybe not. So I'm going to show it to you here as well. But today is we're talking about the guidelines for the adoption of digital pathology in clinical pathology unit recommended by the Polish Society of Pathologists. And if you don't practice in Poland, it doesn't really matter. I obviously am super excited about this being put out in diagnostic pathology by a Polish group. And actually last week I had the honor and the chance to talk to one of the authors, Witold Dresner. And out of this conversation, because obviously I want to feature what's going on in Poland, there is some initiative that I'm going to be embarking on that is going to include the authors from this particular paper, the first author, Łukasz Szylberg as well. But what I want to do is to create a podcast series where I show the trailblazers from each country. And I probably will start with my country of origin, and then I'm gonna invite some people from my country of residence right now, the US. But what I'm gonna do, I'm gonna prepare a kind of structured format because I want to show what's happening in the world, right? We get publications not from all over the world, but I do want to show what's around the world. So let me know what you think about this idea. Do you want pathology digital pathology around the world, or you say, nah, not really, I'd rather do more papers? You let me know in the chat what you would like more of. And actually, I prepared a presentation for you. I used Notebook LM. Notebook LM is my new best friend from AI Tools, especially for paper summarization, paper querying, and all these different things. It's optimized for academic work, so I use it a lot. And I thought I'm going to use it for this presentation as well. If you're just joining, welcome. And let me know if you want digital pathology around the world as a podcast series. And if you know some people, send them this episode where I'm talking about this. And soon enough, there's going to be a framework and like an intake form. But without further ado, let's go into Operationalizing Digital Pathology, a Practical Implementation Guide, Technical Standards, Validation Protocols, and Workflow Integration based on the 2026 Polish Society of Pathologists guidelines, which is fantastic because we are now just at the beginning of 2026 and we have these guidelines. Schilberg et al. In Diagnostic Pathology, presentation created with the help of Notebook LM. I highly recommend. Also, if you would like a tutorial how to make this presentation with Notebook LM, which is going to be like maybe 5-minute tutorial, let me know in the comments that you'd like the tutorial. And in these guidelines, we have the 4 pillars of adoption, because transitioning from whole slide imaging requires satisfying strict technical and procedural criteria to ensure diagnostic non-inferiority. And we're going to talk about this non-inferiority in kind of like philosophical validation terms. But these 4 pillars are hardware fidelity, data integrity, clinical validation, and future integration. We're going to dive into each one of them. Scanners must match the 40x optical objectives. 40x for anatomic pathologists. This is what we're using, and this has to be equal or greater of 0.26 micrometer per pixel, which with most of the scanners, it is 0.25. So whichever scanner you choose, you need to check that, but you should be covered. And then also, monitors must be hardware calibrated for color consistency. We talked on the podcast about color consistency. What about data integrity? Well, the infrastructure must handle high throughput, around 1 gigabyte per slide. It can vary because they can be bigger or they can be smaller, right? With visually lossless compression, 20:1, and secure archiving. Clinical validation is a 2-phase workflow. We're going to dive into it, that is divided into familiarization and dual run to validate the individual pathologist and not just the machine, and leveraging the digital medium for AI-assisted quantification. Basically, this is like the superpower of digital pathology, and we're gonna see tests that are based on digital quantification of markers that actually cannot be quantified by a pathologist visually. It can be confirmed, but not really quantified. And I'm talking about the TROP2 that AstraZeneca was working on and is still working on and is currently available for research use. But this future integration, this is something I am super passionate about, because you cannot do it without digital pathology. You can diagnose without digital pathology. You just do it on the microscope with glass slides. All good, but to incorporate precision medicine, soon enough, this digital is not going to be an option. So let's talk about the scanner. Resolution less than. It has to be more detailed than 0.25 micron per pixel, less or equal to. This is critical for diagnostic fidelity, and we would like at least 200 to 300 slides per day per device. This is going to depend on the lab, because you may need more, you can need less. Maybe if you're only supplementing your workflow with digital, then you can have a less high throughput scanner. But if you're using it for like your general diagnostic work, this is what they suggest. And focus control should be automated with dynamic refocusing or Z-stack, automated for workflow optimal workflow, because if it can automatically focus, then you don't have to do it manually. But in case it doesn't focus well, you need to have the option to do it manually as well. In mapping, full slide capture, excluding label to prevent missed tissue. So it goes, it doesn't go. The slide goes into the scanner usually, and there is tissue recognition, so everything is scanned. I love this. This is Notebook LM version of a scanner, but actually it doesn't look so far from reality. But it looks, the scanner basically is a microscope in a box that scans slides automatically. Let's just smile at the scanner. everybody chooses their own scanner, but basically when you choose your scanner, you look, okay, this was at these parameters, at the resolution, throughput, focus, control, mapping. And their workflow requirement is priority queuing features should be mandatory for handling urgent and intraoperative cases within batch workflows. So it means that you need to have an option to put in a priority case. It can be, so that's a workflow requirement, right? It's not a scanner requirement. If you use a different scanner somehow integrated, you can do that, but it needs to be possible. Now, output specifications. The diagnostic station. The diagnostic station is your monitor and on your computer, right? And you're going to be staring at it for a long time. So it has to be good for diagnostics and good for you as well, so that you can do good diagnostics, or your pathologist can do good diagnostics. So the resolution, 4K Ultra HD preferred. I think it can be a little bit less than that, but that's what they say in the guidelines. 4K is good. Luminescence over 300 candelas per meter squared. Contrast 1000 to 1. Hardware-based calibration, 10-bit color depth. So they require calibration of monitors. And again, I will send you back to this podcast episode that we had with Tom Kimpe and Monica Lambasaini. They talked extensively about color from the engineering standpoint and from the diagnostic pathologist standpoint, and they go deep into why color is important and why actually you should calibrate. We also have specifications for the computers, which is fantastic, because I was recently submitting a publication about our validation, and by our I mean Charles River Laboratories validation of our system for primary read, and what they were, and I was focusing on this pathology component, where like about our philosophy about the non-inferiority, and the reviewers came back like, why are you not talking about specs? And sure enough, I had to put the specs back in. So if we look at this, we have specifications for CPU i7, Ryzen 7 or better, GPU dedicated over 8 GB RAM, essential for smooth panning. So I wanted to do a dramatic demonstration of smooth panning, but you can look at my videos. I recently published new histology videos, so I know this was useful for pathology residents who needed histology refresher. So there I am panning with all force. I guess my computer has enough GPU power to do smooth panning. What about data architecture and archiving? Data architecture and archiving. Data stack that we are working with is daily intake, for example, 30 slides per day. That's 300 slides per day, 300 gigabytes. And these are just examples, right? It's going to vary depending on the institution. And we are taking this 1 gigabyte per slide as also an example. It can be less, it can be more, but let's say that was like the average that they had. So one slide, 1 gigabyte. So this is daily, this is every day, right? And then we have active archive, 6 months to 2 years, right? Why 2 years? That's what they cite in the guidelines, that you should keep these digital images for. And it's going to differ by country, it's going to differ maybe by state, by regulation, but because you need to keep glass, also the like longer period legally required is going to be applying to glass, whereas the digital is going to be probably the shorter period for at least the active archive, right? Where you have to, and I see you guys do want a presentation. And my upcoming publication talks about GLP certification for your system. Yes, GLP validation for primary read of toxicologic pathology evaluation for drug development. And I mean, I submitted the revisions, so I don't know yet when it's going to be out, but you know what? When it's going to be out, I'm going to put it in our DigiPath Digest, because hello, why should I not put my publication and my colleagues' publication if it's about digital pathology? It totally fits. So here, active archive up to 2 years. And then long-term reference, we have physical glass slides, and retention depends how long? 10 years for cytology, 20 years for histology. That's what they are referencing in the Polish guidelines. It differs by country, but they are also working off of the RC Path guidelines. We're going to see it. And if we're doing things in the cloud, then obviously it needs to be compliant. GDPR compliant in the European Union, TLS encrypted connections, mandatory local expert capability. And they mentioned something very interesting and important: no vendor lock-in. Anyway, let's focus on stuff that works. No vendor lock-in is important because you may work with more vendors, you may change vendors. So this local expert is mandatory. Compression and identification QC. We have the original image, and then we have a compressed image. And they look the same to me on this picture. And that's exactly the point. The compression has to be visually lossless. And the compression standards mentioned in the guidelines are ratio 20:1, visually lossless, so no diagnostic degradation. All the diagnostic features are visible. Format TIFF or DICOM. These are open standards. Is that our reality? No, it's not. But we are striving to have standardization in the file formats. So let's keep doing that. There are still a lot of proprietary formats, but this vendor agnostic interoperability concepts, they are making its way strongly into digital pathology. So I think we're going to get there soon, maybe this year. I don't know, not everybody, probably this year. Then the identification of risk. The number one failure point is barcode readability. And the solution is to verify readability at different stages, at the staining and scanning stages. And then important to have a QC protocol, regular side-by-side comparison of compressed versus glass slides for the validation part, right? And that takes us to the clinical validation philosophy. And I like very much this word philosophy because it's not size fits all for the validation. And I think I told you about that a couple of times. But so first of all, the validation, like prescriptions, are going to differ depending on the regulatory framework you are operating within, right? And the philosophy is that this validation is a pathologist-led process. Every reporting pathologist must undergo individual validation. This is a model that is adopted in the RC Path, and it focuses on identifying risks in a real-world workflow rather than abstract testing. And the goal, and this is that was an interesting question that I got from my reviewers, and whoever has done any kind of this work knows that non-inferiority is like a statistical concept for evaluating these scanners and comparing these two modalities. So I got questions about non-inferiority in my publication, but basically what it means is that the digital diagnosis must be as accurate as light microscopy. It's not supposed to be worse. It's not going to be better because we're basically recreating the glass slide. So it's not going to be superiority, but it's going to be a non-inferiority, and scope is individual. Validation is specific to the person and the tissue type. So breast versus GI, and different specialties are going to have different requirements. And I like this one very much on identifying risks in a real world workflow rather than abstract testing. That's important. Or what do they recommend? They recommend phase 1, which is familiarization and retrospective review, the sandbox phase. So they select a data set, in this case 20 archived cases, a mix of small biopsies, resections, stains, H&E, IHC. You can do special stains, difficult features, dysplasia, mitosis. And this is like an across the board concept philosophy. Basically, you want to see on digital what you see on glass, right? And like these difficult features, the concept of difficult features or critical features may be different per specialty. So for example, my specialty ToxPath is going to have a specific list that was published, and also we surveyed our pathologists at work. What do they think is difficult? And we took all these cases. We found cases that had these difficult features. We scanned them, and we have proven, yes, you can see it on digital, right? And then we have dual review on the computer and under the microscope. And this is still the sandbox phase, right? Digital reporting, simulator mode, and glass slide review, when I annotate too much. And then we compare findings, and the goal is technical proficiency with viewer tools, which is taking the pathologist less and less time, because all the new pathologists coming into the workforce, they are screen native, they are digital native, and the tools are also becoming more and more user-friendly. So basically, the learning curve is like you click a couple of times, and then you know where to click, and you are proficient with the tools. But if you're not, or if you're resistant, then you need to work on that, or not do digital pathology. And then we have the second phase, the prospective routine diagnostics. So we do digital first. Pathologist formulates diagnosis on the computer screen and signs out, end state, protocol signed by lab head authorizing independent digital reporting. And then we have also glass confirmation. Pathologist reviews physical slides. And this is like the second part that they do for up to 3 months. And I have seen a version of that in different institutions in different countries. In some countries, and I'm specifically talking about Japan, if you want to do digital, you have to do dual. There's no just digital in Japan. And that's why I admire the digital pathology trailblazers in Japan, because they still have to do both. And then you document the discrepancies. Concordant, no change; minor discordance, clinically insignificant; major discordance alters patient management. And these concepts are also described in a paper published by Roche scientists, by Keith Wharton, who is describing a validation of, I think, 7 different scanners. There's a podcast on that as well. But basically, he describes exactly how did they validate scanners. And these different validation approaches have the same concept embedded. And it depends on where you are, what kind of regulatory framework you're operating under, which bits and pieces, but the concepts are the same. And my favorite thing, AI. And by AI, I mean image analysis, basically. And now it's multimodal AI. So it's not restricted to image analysis. But without digital slides, this is not possible. And if you hear me talking about the visual assessment of IHC scoring, you know that my opinion is strongly against it. And if there was an option to do it digitally, I would do it every day of the week and twice on Sunday. Obviously, visually is the second best. And if we don't have the digital option, then we do what we can. But the option to just even quantify IHC markers with artificial intelligence is something that is a game changer. And now we're entering an era where we're going to have digital diagnostic tests based off of image that are not visually accessible by a pathologist. Some you can confirm, but we are also working on molecular predictions of molecular properties from H&E to supplement or replace molecular testing. And this is only possible with computational pathology on images. But for the quantification, this is enhancing reproducibility and not replacing judgment. There's always a pathologist in the loop. And the key applications that have been there kind of forever since we started doing image analysis on digitized slides was the automated counting for Ki67, HER2, PDL1 is more recent, but we have ERPR. They're not that recent. We have tumor detection pre-screening lymph node metastasis. This is a super cool application that was also used for testing the performance of models in the Chameleon Challenge 2016-2017, and perfect application for AI. And the AI tools must be validated against reference slides, and they must prove non-inferiority to manual counting, which I think is easier than non-inferiority for these digital features, the difficult features. And tech stacks, deep neural networks, and convolutional neural networks. But we have now the transformer architecture that has entered the scene recently. We have foundation models. So the diagnostic tests are often still, the ones mentioned here are often still based on convolutional neural networks, working fine, right? But we now are advancing on the computational side as well. Soon enough, there's going to be more. So there is also the evolution of intraoperative telepathology. So this intraoperative telepathology, and I'm going to take my question here now because this question is related. So let's go through the slide and then I'm going to take the question. So we have the site of the surgery, and then we have a remote pathologist. This has been the application of digital pathology since its inception in remote Canada, in remote Scandinavia. But we also have here some performance metrics, because if they are not met, then it's just so slow, right? So it has to take less than 5 minutes, time from scanning to viewable image, because hello, we're doing a surgery. Time is crucial. And it has to be over 100 megabytes per second required upload speed, safety protocols, microscopic supervision via live video link. So the pathologist needs to know what are they looking at, and there needs to be redundancy. Backup systems are mandatory. Surgery cannot stop, right? So we cannot go and take an RP of this tissue, or call me in half an hour. No. In my opinion, is it possible one day to replace scanners with a special digital camera microscope, which is less expensive and simpler to use? So to replace scanners, what I'm seeing is that you have different technologies in parallel all the time, kind of, always. So it's probably going to be an additional technology that is going to be used in places where this technology, the scanners, are not viable because of infrastructure, because of cost, because of, internet bandwidth. And there are already systems in place that enable scanning from the microscope. So with the camera, it's kind of a manual process. You can have also options with this stage that's moving automatically. There's a word for that. Motorized stage. I was looking for that one. Motorized stage. There's also an option to apply algorithms, digital pathology algorithms, on images. So there are workflows where the pathologist is doing the diagnostics on glass slides, but there is a microscope, there is a camera, and you can take an image, and this image can be analyzed with an algorithm, and the Chi-67 can be counted. So it's like a hybrid workflow. And there are also technologies being developed for scanning, creating digital images directly from tissue without making glass slides. So there are different things happening and different hybrid workflows. So scanner is one way of creating these digital images. Digital camera is another one. Smartphone is another one, right? The question is always, okay, how do we stay compliant? How do we stay non-inferior? And then second, how do we stay compliant? But yes, start digging, looking at the podcast, looking at publications. I have people talking about alternative options that are more economical or optimized for different setups. So the answer is yes. The short answer is yes, there are options. And we also have a checklist. Infrastructure, certified scanners, it can be CE IVD in Europe, FDA cleared. But there is an option to have digital pathology as a lab developed test as well, right? But regardless if it's going to be a cleared device, if it's going to be a CLIA framework for LDTs, you need to have certain specifications, and the resolution needs to be enough. It has to be 0.26 microns per pixel or higher. Monitors need to be calibrated. Storage needs to be scale validations. So in this particular models, pathologists complete phase 1, then pathologists complete phase 2, where they do the dual run, and then you review the discrepancy protocols. And if you reached a certain level of non-discrepancies, which most of them over 90, I don't know, definitely over 90, but I don't know if over 95, then you're good to go. And the QC procedure is active, visual versus compresses checks, barcode readability verified at all stages. So this risk assessment is also an approach being taken in the GLP validation that we did. You basically identify risks and figure out how can we mitigate them. You want to look at the full publication. It's guidelines for the adoption of digital pathology in clinical pathology units recommended by the Polish Society of Pathologists, Diagnostic Pathology. And they say digital pathology is not merely a change of medium, but a shift toward greater precision, efficiency, and integration in modern healthcare, which I truly believe this is the case. And, if you're looking for what the specs should be, how you should do it, this is a cool publication that you can use, very recent. And now it's time for the gift. The book is a gift for you because the PDF is entirely free. The paper version is available on Amazon. So if you want to, highlight and have the physical copy, totally available on Amazon. But if you want a searchable PDF at no cost, other than me sending you emails, that is the cost, then you can scan the code now. And so the thing that I prepared for you today is audio bundle. It's an audio bundle also created by Notebook LM of the 7-part AI in Pathology series published by Rashidi et al. In Modern Pathology. So I also have this Pathology AI makeover course. I'm putting both of these codes on the screen right now. In the corner, you're going to see the course. So the course is also based on these publications, but it's long. It's good. It's like you're gonna learn really well, but I realized that not everybody has the bandwidth to go through like a 5-hour course or I don't know, it's probably longer even, but they would still like to learn the concept. So what I did, I created the audio bundle, AI powered audio bundle, where you can listen to the publications, because there's another tool I use for that. I'm going to tell you about that, for like basically listening to publications as I do other stuff. But these are podcasts created by Notebook LM that are based on these publications with a specific prompt that like tells Notebook LM who is listening to this podcast. So I described you precisely. So if you want to get the information from that pathology, AI in Pathology audio bundle in under 2 hours, that you can, it's pretty like in an entertaining fashion, pretty well explained without dumbing it down. This is your resource. It's a $19 resource. And there's going to be more of that because I did publish this on social media already, and a few of you got the bundle. So I am looking forward to your opinions. Let me know what you think, because what's happening, we have these live streams, right? And usually we are discussing abstracts. So we have like 5 abstracts per live stream, and we just look at the abstract and we think, okay, fantastic. It's a good paper. Should I read it? Yes, definitely I should read it. Do I ever freaking read it? No, because life happens and you have to do stuff. So, but kind of like the success in a discipline like that is very fast moving, depends on us reading these papers. So this is my shortcut. It doesn't replace the reading, but my shortcut to learning a bit more than what we do in the abstracts in DigiPath Digest. DigiPath Digest stays, and we're going to keep meeting every Friday, almost every Friday. But I am going to be creating these AI-powered podcasts from different publications, and I'm going to tell you about that next time. For today, that's it. If this AI in Pathology audio bundle is useful, let me know. I listened through it all, and it was very useful to me as a refresher. Even though we read all the publications on DigiPath Digest, they are included in the Pathology AI Makeover course. So I already knew it. When I listened to this, I got a cool refresher to basically stay on top of things. Next week, we're just going back to our normal DigiPath Digest, and I'm gonna be announcing some new plans. Let me know if you want this presentation that we had today. Let me know if you're interested in the Digital Pathology Around the World podcast series, and I talk to you in the next episode.